Thank you very much. Good afternoon, everyone. Thank you, Prokar, for this very, very nice introduction. Thanks a lot. I'm honored and pleased to be here, and I will try to talk to you in the next 20 minutes about a difficult topic, about the evidence and the controversies for partial nephrectomy and its different approaches for the treatment of localized renal tumors. We all know that we are seeing today more and more renal tumors in all age groups, and we have witnessed a significant stage and size migration. We are seeing more and more localized and smaller tumors. And there is no doubt that surgery is currently the recommended treatment options for localized RCC. However, we have witnessed over time a significant paradigm shift from the old Robsonian concept of radical removal of the entire kidney and surrounding renal fat to the more modern concept of nephron-sparing surgery, which has been supported in the early 90s by Andy Novick at Cleveland Clinic for imperative indication and later expanded to relative and elective indication in bilateral kidneys. This paradigm shift has led today to the definition in the major urological guidelines of nephron-sparing surgery as the recommended treatment options for all T1A tumors and also for T1B tumors whenever this is technically feasible. So, well, where does this evidence come from? Where are these statements supported? Well, let's look at the evidence. And once again, unfortunately, the high-level evidence is not there yet. However, partial nephrectomy has been initially increasingly used due to the increasing understanding on the small renal tumor histology and on the relatively small oncological threat the small renal tumors represent for the patient's life. But on the other hand, for the increasing evidence of the oncological equivalency of partial and radical nephrectomy for localized tumors. This came initially from single institutional studies like this from Germany, and then from larger multi-institutional studies showing similar cancer-specific survival rate for partial and radical nephrectomy. Also, the estimated risk of death from renal cancer was not found to be significantly higher in the nephron-sparing surgery arm in the only level 1 randomized phase 3 trial of radical versus partial nephrectomy for less than 5 centimeter renal tumor led by Hein van Poppel, although this study, we know, was limited by a premature close due to pure accrual and by the relatively small number of renal cancer-related deaths. Another crucial point for the expansion of elective indication for nephron-sparing surgery is the better preservation of renal function with partial nephrectomy in the setting of emerging concerns about chronic kidney disease and its potential adverse effects on survival and cardiovascular health. Landmark studies like this from Memorial Sloan Kettering showed that in patients with normal serum creatinine and 2 kidneys, the probability of freedom for an eGFR less than 60 after surgery is significantly higher in the partial nephrectomy group compared to the radical nephrectomy group. And if we look at the functional outcomes of a EORTC trial, once again, they confirm the superiority of nephron-sparing surgery to prevent at least moderate chronic kidney disease. As you can see here, at the last follow-up, nephron-sparing surgery, only 38% of patients treated with nephron-sparing surgery had an eGFR less than 60, compared to 58.7% of patients in the radical nephrectomy arm. However, if we look at very low eGFR values, we can see that there is a low and similar proportion of patients that reach these values in both treatment arms. And in fact, if we look at the follow-up of these patients in this study, we can clearly see that nephron-sparing surgery is clearly able to achieve better eGFR values after surgery. But if you look at the radical nephrectomy group, there seems to be no significant progression of renal functional decline over time, with most patients avoiding severe chronic kidney disease and dialysis. Further attention in this field has been driven by these large, very well-known studies on a very large US population of patients mostly without renal cancer and without previous renal surgery, showing that the lower the eGFR, the higher the risk of death, cardiovascular events, and hospitalization. And actually, this led to several retrospective studies that clearly show that, for example, if you get a nephron-sparing surgery, you have a significantly lower risk of developing cardiovascular events during follow-up compared to radical nephrectomy. And to several other studies that showed or tried to show that the lower decline of renal function with partial nephrectomy may even lead to a better overall survival with this technique. However, if we look at other studies, this is a population-based study based on the SARE database, and very surprisingly, the author observed that partial nephrectomy patient had even better overall survival than non-cancer patient, while this was not true for radical nephrectomy. And this clearly suggests that the overall survival advantage of partial nephrectomy may be due to selection bias and to the presence of unmeasured confounders. And this hypothesis is actually well shown by the results of the randomized trials, where there was no overall survival advantage for partial nephrectomy over radical nephrectomy. So why is this? Why is there is no survival advantage for partial nephrectomy, although partial nephrectomy is able to achieve better eGFR values? Well, the answer is probably coming from these nice studies, very recent studies from the Cleveland Clinic group. The author observed that the progressive decline of renal function is significantly more pronounced in patients who have a preoperative eGFR less than 60, while patients with a normal preoperative eGFR are far less likely to develop severe chronic kidney disease and to need dialysis, even if they reach an eGFR less than 60 during follow-up. And this can be also translated to overall survival. And once again, the overall survival is much poorer in patients with a preoperative eGFR less 60 compared to patients with a normal preoperative renal function, either if they reach an eGFR more than 60 or lower than 60 during follow-up. So that probably means that radical nephrectomy could be safely employed in patients with 2 kidneys and normal preoperative renal function or good eGFR values without a significant risk of progression to severe CKD, dialysis, and increased overall survival, especially when their tumors are challenging to remove with increased risk of complication. While partial nephrectomy remains an imperative indication in these patients with fragile pre-op renal function, which they are at higher risk of progression or the renal functional decline. The same author also observed that only patients who reach an eGFR less than 45 after surgery actually had an increased risk of severe CKD during follow-up and of increased postoperative overall mortality. Other propensity-matched multicenter studies showed that the potential overall survival advantage of partial nephrectomy is actually not confirmed if we restrict the analysis to the older population of patients older than 65 years old. All this together clearly says that when we want to choose whether to do a radical or a partial nephrectomy for a tumor, we should not only look at tumor characteristics, which can be summarized with the anatomical classification system, but we should also very thoroughly look at patient characteristics, mainly age, comorbidities, and preoperative renal function. And that radical nephrectomy can still be a safe option in older patients with 2 kidneys and the preoperative good eGFR values. Once the unmodifiable patient-dependent factors are taken into account, what are the other factors modifiable and surgeon-dependent that can predict postoperative renal function? Well, of course, warm ischemia time and also the proportion of preserved healthy parenchyma, that is kidney quantity, which depends on the amount of periregional parenchymic size and on the amount of parenchyma we ischemize with the renography. Warm ischemia time has been always considered the strongest predictor of postoperative renal function, and studies on solitary kidneys, mainly from Mayo and Cleveland Clinic, clearly showed and led to the hypothesis that every minute counts when the renal ileum is clamped during partial nephrectomy, and they found a cutoff of 25 minutes to identify those patients at higher risk of long-term renal dysfunction. However, this is again very controversial. And this very nice study looking at functional and ultrastructural changes of human kidneys after partial nephrectomy, doing renal biopsy before, during, and after surgically induced renal clamp ischemia, clearly showed the renal functional changes did not correlate significantly with ischemia duration. And that actually human kidneys can probably safely tolerate much longer ischemia times than we thought, with only mild structural changes and no acute functional loss. What we know, and when we put warm ischemia time in multivariable analysis as a predictor for long-term renal function, well, it is not a statistically significant predictor, while the only two independent predictors are preoperative GFR, that is renal function, and the percentage of parenchyma we preserve, leading to the new concept that actually long-term renal function after partial nephrectomy is primarily determined by the quantity and quality of renal parenchyma preserved. However, type and duration of ischemia remain the most important modifiable factors, and is definitely able to influence post-operative renal function and the risk of acute renal failure, but once again, it fails to predict very well long-term significant renal failure. More or less the same concept have been developed in studies looking at bilateral kidneys with differential scans with a group of Francesco Porpiglia in Torino. We observed that the kidney damage occurs during lap partial nephrectomy when the warm ischemia is 30 minutes, and that this damage is only partially reversible over time. And once again, several studies led to the definition of the ideal cutoff of 25 minutes to identify those patients who will be at higher risk of post-operative renal failure. And once again, also in the setting of bilateral kidneys, the percentage of parenchyma preserved assessed by imaging or by intraoperative surgeon assessment is always a very strong independent predictor of postoperative renal function. Having said all that, the use of partial nephrectomy has definitely increased in the last 15 years. These are data from the United States. It increased significantly from 20 to almost 50%, overtaking radical nephrectomy, which is decreasing over time. The increase has been steady over time, and very interestingly, unfortunately, it was not strongly influenced by the release of the AUA guidelines on RCC in 2009. Here in the UK, you are doing a very good job, and actually looking at the BAUS nephrectomy audit, in 2012, 56% of partial nephrectomy of tumors, T1A tumors, were treated with partial nephrectomy, and 1/5 of T1B tumors were also treated with nephron-sparing surgery. The last point to touch is that we definitely observed a minimally invasive evolution of partial nephrectomy from open partial to lap partial to robotic partial in the last 2 decades. Long-term follow-up data clearly shows that the oncological outcomes are the same also with a minimally invasive approach, so that partial nephrectomy can be performed according to the guidelines, either with an open, pure laparoscopic or robotics-assisted approach based on surgeon expertise and skills. However, pure laparoscopy is clearly associated with a higher risk in large studies of post-operative complications and bleeding, and in very experienced hands, like Hindi Gill's hands, actually took 200 cases to significantly decrease the number of complications, suggesting that the learning curve is very long and steep. And furthermore, of course, warm ischemia time is always significantly longer with laparoscopy due to the intrinsic challenges of this technique. Several technical modifications have been developed to decrease warm ischemia time. One is the early enclamping technique, you all know, that was able to decrease warm ischemia time and the eGFR change after surgery. And more recently, there is increasing attention for off-clamp partial nephrectomy. That means performing partial nephrectomy without any clamping of the renal vessels. Again, study on solitary kidneys clearly showed that no ischemia is definitely better than warm ischemia in order to maximize post-operative eGFR values. However, if you look at this interesting study by Francesco Porpiglia, again, in bilateral kidneys, they look at split renal function, and they observe that at 3 months post-op, actually, the split renal function of the operated kidney in those patients who had no clamping was actually a little bit worse than patients who had a short warm ischemia time, but this difference was not statistically significant. Another proposal was that of selective clamping, that means just clamping the branches of the renal arteries feeding the tumor. With the use of this approach, again, Hindi Gill was able to show a significant decrease in eGFR change after the surgery. But once again, we need further studies and more evidence. If you look at this very difficult slide, so just look at the first and the last column, this author compared off-clamp, selective artery clamping, and main artery clamping. And they observed that actually these new approaches were able to improve or to reduce the eGFR change after the surgery, but this was only statistically significant in the first 3 months, while the last follow-up they lost statistical significance. So we need further studies to really understand whether these new techniques can really help to improve long-term renal function. Finally, we observe in the last few years the development of robot-assisted partial nephrectomy. We know that this technique can make the suture easier, can make the tumor excision more accurate, can accelerate the learning curve. In the last meta-analysis was published on about 2,300 robot-assisted partial nephrectomy. There were no significant difference compared to laparoscopic nephrectomy in terms of operative time, estimated blood loss, complication rate, and positive margins. However, the robotic approach was able to lower the rate of conversion to open a radical surgery, to shorten the length of stay, and, which is most important, to significantly shorten warm ischemia time and to obtain smaller eGFR change. However, this data needs to be confirmed in prospective, ideally randomized studies. It is quite clear that the robotic technology helped the urologist to extend the indication of minimally invasive partial nephrectomy to more complex tumor, and that has led, at least in the United States, to a significant further diffusion in the last few years, as you can see here, of partial nephrectomy. To come to conclusions, while nephron-sparing surgery is definitely today the gold standard for the treatment of localized renal tumor, first of all, because it has comparable oncological outcomes to partial nephrectomy, to radical nephrectomy, because it allows better preservation of postoperative renal function, because it can also avoid progression to severe CKD in patients with solitary kidneys or with lower preoperative eGFR values, and in this patient it may also decrease the risk of cardiovascular events and improve overall survival. Renal functional outcomes after nephron-sparing surgery are strongly associated with preoperative renal function and the amount of kidney we are able to preserve. There is uncertainties about the exact impact of type and duration on ischemia on postoperative renal function, but warm ischemia time have a significant impact on postoperative renal function, and longer warm ischemia time, more than 25 minutes, should be avoided, with cold ischemia employed if we are expecting longer period of ischemia, especially in the imperative setting. In experience sense, laparoscopic partial nephrectomy can be performed and it's oncologically safe. However, it's associated with a higher rate of intraoperative and postoperative complications, longer warm ischemia time, and a long and steep learning curve. The robotic technology can definitely overcome the drawbacks of pure laparoscopy and allow wider indication for minimally invasive partial nephrectomy. No or selective ischemia techniques appear to lead to better renal functional outcomes compared to warm ischemia technique. In experience sense, for those tumor amenable for this challenging approach, accepting a higher risk of bleeding and complications. And finally, we definitely need the rigorous evaluation by clinical trials, ideally randomized trials for robot-assisted and selective ischemia techniques in order to really define the current ideal approach for nephron-sparing surgery. Thank you very much for your attention.
Fantastic talk, Alessandro. I see Ben Chalacom walking towards a mic. He has just written a blog where he takes offense to the fact that everyone says a randomized controlled trial is necessary, and he puts in his blog, please say something else. So, Ben Chalacom.
Professors, yes, my other one was about the word steep learning curve, because of course it's not steep, it's shallow, because it takes a very long time. But Alessandro, what do you think about lap open robots? Should we be somehow tailoring which people do this? I feel that perhaps open is very good for really complex tumors, but the rest we should perhaps be moving towards robotics. Is that how you feel it's going?
Well, thanks for the, of course, very important question. I think that the first goal is really to achieve nephron preservation whenever this is clearly indicating. That is, especially in those patients, as we have seen, that have a long life expectancy and have a fragile renal function before surgery. So in these patients, the first goal is to achieve nephron preservation, either with an open lap of robotic approach. So that depends, of course, clearly on the skills of the surgeon, and you should select the technique that is best in your hands to achieve the goal, that is good preservation of the nephrons and low complication rate. However, in the ideal world, I think that open partial nephrectomy, at least in my hands, is reserved to very, very complex cases. And if you have a robot available, which is not possible everywhere with the current economical issues, especially in my country, actually, you should reserve the robotic technology for treatment of very complex tumor, and in these cases, with good experience, you can really achieve more or less the same results you can achieve with open surgery, treating very highly complex cases.
So, Alessandro, let's do a show of hands from the audience. How many in the audience do a open partial nephrectomy, please? And how many do a lap partial? So lap is actually slightly more than open, and robotic partial?
Few.
So I see one hand, and that is Ben Chalacom's. So, he is the highest volume robotic partial nephrectomy.
Ask them how many would do it robot if they had one.
Exactly, that's where I was going. So to the lap and the open guys, if we gave you a robot for free tomorrow, would you move to robotic partial nephrectomy?
Yes.
In fact, they've all raised their hands. I rest your case. So moving on, Frank Keeley, please.
I'll just say I didn't raise my hand. But
Frank,
sorry.
you're the odd one out.
So, yeah, I am. I freely admit to that. And in fact, it's a question for both of you, because the one systematic trial meta-analysis that you presented there involves historical laparoscopic partial nephrectomies when Indy Gill, Luca Vusi, and other pioneers were learning the technique, comparing it to the last 5 years of robotic partial nephrectomies. And if you look at all the things we've learned over those years, it is such an unfair comparison. However, the literature is biased towards what's new, and laparoscopic partial nephrectomy is not new anymore. So the last 5 years is full of robotic partial nephrectomies, and actually laparoscopic partial nephrectomy, if you were to do a comparison not in the literature but in the real world, would not fare quite as poorly because of early declamping, lower warm ischemia time. I mean, you mentioned laparoscopic partial nephrectomy having warm ischemia times over 30 minutes, and that's just not reality today. In experienced hands, it's 14, 12 minutes, whatever. So maybe a question for both of you might like to comment. How do you address the time lag in these publications? We're comparing open from very old data to laparoscopic from 10 to 15 years ago to robotic, which is modern day. I think that systematic review was the most biased one in my field that I've seen, and everyone quotes it and tweets it. And it all is just propagating a biased analysis of very different outcomes. So I wonder if both of you could address
Philippe
that.
first and Alessandro next. Philippe?
So this is one of the challenges of systematic reviews and meta-analysis of observational data, right? That you have a big problem with selection bias, and you're potentially comparing apples with oranges, and I think that's what you're essentially describing, that procedures that were done 5 to 10 years ago do not represent the standard of care of what we would do today, and which emphasizes the need for randomized controlled trials, and sometimes the results of those trials actually surprise us by actually showing that things don't work or don't work as well as we think they did. We think they should.
Alessandro?
Well, I agree. I think that the window of opportunities to design properly trials is very short, and we generally tend to miss it, unfortunately. And you are completely right that we tend always to compare the new technique to the old technique, and then we are biased both ways, in my view, because of course the old techniques is established. On the other hand, with the new techniques, you tend to treat easier cases at the beginning. So on the other hand, to get probably better results, although in the first part of the learning curve. So I think that the message would be to really try in the urological community to increase our ability to design proper studies when there is still the window of opportunity to design those.
But further to that, if I might say, the reviewer of a the person conducting a systematic review might look at it and say, all of these studies are not studies. They are single-center, retrospective presentations of data. There's not a single methodological thing you can support in any of the data. And I think dressing it up as a meta-analysis or systematic review when it's purely single-center retrospective studies is, promotes poor data into, anyway, you know what I'm saying, Philippe?
I agree.
We agree.
Yeah, so that maps to the, that is one of the systems that we use to rate the quality of evidence is the Oxford system that has these levels of evidence, right? And systematic reviews are given a very high place, but I do think we need to drill down and look more carefully how well was this done. So I agree with your comments.
Microphone 4 and then 1, and I just want to bring Hein van Poppel to microphone 2 for a last word. Microphone 4, please.
Okay, I have two questions, one for the first speaker, one for the second. For the first speaker, you continue to see randomized controlled trials. There have been several publications recently telling us that there are many issues where we can't conduct randomized controlled trials, and the fact that systemic reviews essentially look at randomized controlled trials doesn't mean always that they're best. And my second question is for the second speaker. You've provided an excellent talk about partial nephrectomy. You've given us a lot of evidence, and your final conclusion was we need more evidence. So as a urologist, I cannot look at all of the evidence and then think, well, we need more evidence. This is a problem.
Two punchy answers. So Philippe first and then Alessandro.
So I don't think we have a disagreement. Systematic reviews can be a tool to look at how well a randomized controlled trials were done. And maybe just to add, there's a lot of room for improvement in our observational studies. They could be prospective and they could be done a lot better, and we can get better evidence there too.
Well, the answer is simple. Unfortunately, I said at the beginning of my talk, I was talking to you about the evidence and the controversies. Actually, in this field, the evidence is very low. The high-level evidence is very low. And so right now, we are still using mostly retrospective data. The big databases that support most of my conclusions are the big, large North American retrospective database on solitary kidneys. And therefore, once again, this is just a big trigger for all of us to work better, to put together prospective data, and to compare treatment when there is still the opportunity to do it.
Good news is that initiative has started internationally, where every data on every time point is being collected through the Vattikuti Foundation into a prospective database. Neeraj?
Just a comment. One of the biggest problems with the partial nephrectomy is that the hyperfiltration post-surgery and the monitoring of an EGFR as an end point to whatever you are using as a comparator for 3 different techniques. If we are having data beyond 1 year as your baseline for your EGFR to compare the outcome for nephron sparing, beyond that point, the health of that individual, hypertension, diabetes, anything else may contribute to a false result, and therefore you cannot make meaningful comparison. So your endpoint of what you're primarily trying to save remains unaddressed, and your endpoints at 1 year probably might be more sensible.
So I'll give you my own thoughts, but Alex?
Well, of course, again, the limitation of most of these studies, the short follow-up, especially for functional outcomes. And in the setting of bilateral kidneys, there are very few good quality studies using differential renal scans. And this is the only way to answer your questions, actually. But it is difficult to do logistically, economically, so there are issues about that. And again, we need to address it with protocols, with well-done protocols, and we have to follow them and to collect data. That's the only way to respond. I agree that at present we don't have the final answer.
So let me tell you this. Last week I accepted a very controversial follow-up to the Dipen Parekh paper which he showed. So even after warm ischemia of 30 minutes plus, at mitochondrial level, beyond a year, there is no difference. Yep. And this study has been heavily criticized. It was beautifully done, and at ultrastructural level, there's no difference. I accepted it, despite the criticisms. So there are unanswered questions. So final word from Hein van Poppel. We have great pleasure in having him here. The only man who said that radical nephrectomy in his randomized trial was better than partial. Hein, where do you stand on this?
I continue to believe that the trial stands, and the results are there. It's the only randomized trial. It has been heavily criticized, and there were shortcomings, I'm absolutely sure. We needed to have 1,500 patients. In the end, we ended up with less than 600. We did the reanalysis. It was the idea of admissing. We need to find out what happened to these patients. So we calculated the eGFRs and looked at 10 years and longer follow-up, and there's actually no difference. So what do we have now? We're talking about systematic reviews, and the only one that has been done is the Capitano paper. Now, it has been mentioned this morning earlier during the kidney cancer session. If you look at the two curves, where there's an improvement in eGFR in the radical nephrectomy versus the partial, where comes the difference from? Finally, it's a banana that closes after 15 years and get together. That's the first important point. And everything that is making the split of the banana occurs in the first months. So what has happened in all these trials? The inclusion for getting a partial nephrectomy or a radical nephrectomy is biased highly by the selection of the fitter or the less fit patient. And I think that's all. That makes the difference in all the meta-analysis or in the evidence-based and whatever trials that have been done to show that partial is finally impacting on survival, which I do not believe. So what's the place for partial nephrectomy? It's in patients that have a danger, that it's imperative kidney-sparing surgery. There's the place. How can you do a good imperative kidney-sparing surgery if you're used to do many elective kidney-sparing surgeries where you can remove the kidney when you fail? So there you get experience. And that's the big advantage of all these cases that we have been doing partials on, because we thought it was better for kidney function and cardiovascular death. So, partial nephrectomy is there to stay, but not in everybody. So you cannot blame a urologist working in a smaller hospital with a lower caseload that he does a safe laparoscopic or robot-assisted radical nephrectomy for a difficult case with a normal eGFR and a normal kidney function preoperatively. Thank you.
Gentlemen, you have done a fantastic